So a few people I'd like to thank. First of all, thank you, Sapna. This was your idea and your hard work for putting this together. So thank you very much. It's already been a lot of fun. Second people I'd like to mention, in fact, actually, are Brian Rennie and Tom Pole. So I've been, I know them both because I treat kidney cancer, and I've been listening to their podcast, Uromigos, with lots of other people actually for the last few years. And I think it's great. And I think it's also been really influential. So I think certainly for me at least, it gave an idea of what could be done with this type of thing. And it'd be great if we're able to do something in the melanoma space that has the prominence that theirs does. So let's wait and see. And then third and final thanks is to David Gedge and the wedding present for very kindly allowing us to use their music for the beginning and end of the podcast. So thank you very much, David. Hope you enjoy it. Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, and welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin.
Today we're going to be discussing some frontline metastatic melanoma trials, the CheckMate-067 study. So James, if you're ready, let's jump into 067. You're the guru of this study. Let me find the original citation, actually.
Yeah, so thanks. So this trial started recruiting in 2013, I think, end of 2013. And the first results were presented in 2015. And actually, Jed Wolchok presented that at ASCO that year. And there was a paper in NEJM, and myself and Jed and Steve Hody were sort of leading and senior authors on that. So that's the sort of background. Since 2015, we've presented data at lots of meetings and published manuscripts as well. So overall survival at 3 years, overall survival at 5 years, and the 7.5-year follow-up presented and published last year.
Because we definitely heard a 4-year and then a 6-year and then an 8-year.
Yeah, who knows what set the precedent? I think presenting overall survival data, that's obviously important as soon as you've got it. So that's 3 years. I think 5 years, you could say, well, what's special about 5 years? But you could ask a lot of oncologists that question. We talk a lot about what happens at 5 years. So I think that's the justification for that. My view on follow-up after 5 years, when you're talking about potentially curative treatment, is it's really important to know what happens after 5 years, ideally up until 10 years. Beyond 10 years, it's difficult to know, I think, if the data are pretty stable and mature, whether further follow-up for efficacy is going to be, let's say, that illuminating. But on the other hand, you've got the issue of disease-specific survival, which is one thing. And then the other one is long-term side effects of the drugs, for drugs that we've only really been using for a fairly short period of time. But then that, I think, becomes quite difficult. The question, we've talked about this a bit before, how easy it is to really get traction on long-term side effects from sort of registrational studies. So anyway, so I guess that's the background.
So just for anybody who's listening who wants to mark the Sentinel paper here, it's the New England Journal of Medicine 2015, July. James, you're the first author on this. Jed is the senior author, and the title of this is Combined Nivolumab and Ipilimumab or Monotherapy in Untreated Melanoma. This was the first report of the CheckMate-067 trial in frontline metastatic melanoma treatment. So this study, just to summarize it, was a randomized phase 3 study, registrational design, 3 arms, patients were randomized 1:1:1. Almost 1,000 patients here, 945 with advanced melanoma untreated were randomized to either nivolumab alone, nivolumab plus ipilimumab, or ipilimumab alone. And there were two co-primary endpoints here: progression-free survival and overall survival.
Yeah, so I'll just start with a small caveat, which is what we always say, that the trial wasn't powered for a comparison between the Nivo arm and the Ipi-Nivo arm, although that's, of course, what we're interested in. Standard of care at the time the trial recruited was Ipi mono, but accepting all of that, pretty much what we showed in the first readout was the superiority of both the Nivo arms in comparison with Ipi for PFS and response rate. Maybe just to focus on response rate, because I actually think it's quite important. The response rate to Nivo mono, sort of 45%, that kind of ballpark. Ipi Nivo, high 50s. Ipi mono, around about 20%, what you'd have expected, I think. So that's the efficacy summary. The exploratory comparison between the Nivo containing arms, numerically, Ipi Nivo, as I've said already, was superior, but that wasn't specified a priori statistically. And then I guess the other thing is side effects. So Ipi mono performed as we expect, and I normally quote a rate of about 20% for significant AEs with Ipi mono. Nivo mono, sort of 10 or 15%, so less toxicity than Ipi mono. And then Ipi Nivo together, you're talking about a rate of significant AEs up in the sort of 30-40% type of area. And that's kind of what I say to patients in clinic. There's a few other things to say, I think. I mean, I'm not sure we knew all this stuff at the beginning, but quite often you'd end up having to stop the Ipi-Nivo in the induction period, which is the first 3 months, because of side effects. And I think subsequently we found out that in that group of patients, actually the efficacy looks at least as good as the people where you don't have to stop for tox. And actually Dirk Scharendorf's a lead author of the paper showing that in JCO. So I guess that's where we were at the time. Maybe a couple of personal comments, if I may. Yeah. So I actually had to make a really kind of strong case for us to be able to even do that study in the UK in the first place. I remember this really clearly. And I talked to someone from BMS, whose name I don't know if we should mention or not, but anyway, because at the time, and I guess this was in 2012, 2013, the track record of the UK in terms of opening quickly and recruiting wasn't that good. And so BMS didn't have a lot of confidence in our ability to recruit. And I kind of almost begged to say, look, what we'd seen already at that stage from non-randomized studies for Ipi-Nivo, it looked so dramatic. I was really keen to get the study. That's one thing to say. And the other thing to say actually is when go on.
Well, let me ask you, did you end up as first author then because you opened with the boom and put so many patients on?
Yeah, in a nutshell. I'm not going to say there wasn't sort of contribution academically as well, but we put lots of patients into the study. The other thing I was going to say, which is really nice actually, when Jed presented the data at ASCO 2015, is that I'll say who it was. I think it's fair. Joe Cowler from BMS came up to me in the audience at ASCO and said, "James, look at this. This is great." And that was just a really nice moment actually. Because
it's cool that you petitioned to get the study opened, and then not only opened but produce so well on it.
Yeah, the other thing I would say, which I don't know how well this will play in general, is that as soon as we started using anti-PD-1 in clinic, it was really clear that this was a very, very active treatment. We were seeing things that we'd never seen before, particularly in terms of how quickly anti-PD-1 containing regimens work, because we've been used to Ipi mono, which, if it's going to work slowly and all that sort of thing. And, we had symptomatic people in clinic would start on treatment, bearing in mind this is a blinded trial, actually, CheckMate-067, but we'd start someone in clinic who had symptomatic disease, and then we'd see them again 3 weeks later and they were kind of back to normal. And you just don't really see that with Ipi mono. So to me, to see the results was great, but actually we kind of knew already I think that
Yeah.
this was an active treatment. Anyway, sorry.
Well, I have some questions for you. I mean, this was, when you talk about objective response rate, this was one of these studies early on that didn't have central review. These were investigator assessed responses, right?
Yeah, absolutely. And
Yeah.
I mean, that's kind of the subject of a podcast in its own right.
Yeah. Yeah.
And I guess, the pros and cons of that. And I suppose the thing that comes up now is the question of how you compare it, let's say, with studies that do have also have had central review. So
Right.
I think that's another of the considerations that you have for cross-trial comparisons, which of course we shouldn't be doing cross-trial comparisons in the first place, and there's lots of reasons why you can't do them, although we do them all the time. But I wouldn't, in a way, I wouldn't focus too heavily on scan review, honestly, because now, at least for this study, got OS data. So
I think my point was more related to what you were making about ipilimumab. So with Ipi, what we were seeing in a percentage of patients, maybe 15 or so percent of patients, was the pseudo progression, where things would get worse before they would get better. You didn't see that symptomatic improvement as quickly. And so there was a tendency in some of the early Ipi trials to take people off during the induction period because of growth. And what we knew from chemotherapy in those early targeted therapy days is if you had growth, that was a bad thing. We didn't see that as much with the PD-1 containing regimen. So when an investigator assessed a response as, a response, it often was believable. When it was progression, it wasn't progression that was a danger of being pseudo progression. It was probably real progression and confirmed. But there is something that I've heard over the years sort of bandied about, which is in the CheckMate-067 publications, the response rate, as you noted, in the combination arm is these high 50s. But then I will hear, and it's a modern message, and maybe that's to go along with some modern treatments that have emerged. I'll hear, well, that's an unconfirmed response rate, and the confirmed response rate is really high 40s. What is your take on any of that? Is that just hand waving, or is it real?
a little bit hand waving, I think. I mean, maybe one initial comment is that we got the trials, but I think the efficacy in clinical practice is going to be determined by a few different things, LDH, PS, that kind of thing. So I would just mention that. But what I was going to say actually is kind of in my experience of using this combination now for best part of 10 years, and having treated a lot of patients, it actually feels to me the response rate might actually be higher, or let's call it the clinical benefit level, even higher than that. And I think some of that reflects learning, as you just said. I mean, I saw someone in clinic this morning who high LDH baseline, Ipi-Nivo, few side effects over the last few weeks. We ended up doing a PET scan for reassessment, not something I'm that keen on if I can avoid it, because I think PETs can be difficult to interpret. And this is someone who actually there were areas of progression, okay, but this was a patient who felt a lot better. And I said to the patient, was a bit worried about the scan, and it had been reported as a mixed response. And I said, well, look, actually, I think most of these are going to turn into decent responses. And actually, she had BRAF mutant melanoma. So if you wanted to, you could have started the patient on targeted therapy today, but I haven't. I'm just sitting out. She's got a bit of tox, and I'm going to put her on Nivo mono in due course. And I think she's going to be one of those long-term survivors. So, it's a kind of weird answer, but it feels like actually the efficacy may even be a bit higher than that. Certainly, my experience.
You're right. I think what happens when you have some experience using the combination is you get an instinct about which patients to sort of pull the trigger on it with. And if somebody, it runs the gamut from low volume disease to high volume, high burden disease, because we know this combination is effective throughout that disease spectrum, including in the brain. I think CheckMate-067 in the more recent reports have done something which is probably precedent setting for our trials moving forward, reporting melanoma specific survival rather than overall survival. Because now that we see this combination improves overall survival, the real question is, what are the patients? Are they dying from their melanoma, or is it something else? We really want to see that these drugs improve melanoma specific survival. That's a very meaningful measure. So we have to change the way databases capture death, not just is the patient alive or dead? Yes, no. It's what is the cause of death? And then it's the best, association. So we can start to do endpoints like melanoma specific. But also the treatment-free intervals that CheckMate-067 started reporting. Treatment-free intervals is wildly important to patients coming off treatment, getting time back in their normal life, hopefully coming off tox and that sort of stuff. So these treatment-free intervals are really important. And I think you highlighted that treatment-free intervals after immune checkpoint inhibitor, particularly the combinations, does not necessarily compromise your long-term benefit. So you can be off treatment for toxicity. You can have a long treatment-free interval. Mainly these patients came off because of toxicity rather than completing the regimen, and they're still deriving the benefit of that combination up front.
Yeah. And, I mean, maybe I hinted about this with my comments about stopping for toxicity, but, in the trial and in my experience, that there've been, I would imagine, dozens of patients by now who've only ever had 1 or 2 treatments of ipi/nivo for their metastatic melanoma with stop for tox, and they're long-term survivors. So in these sensitive situations, I'm pretty certain you don't need much treatment actually, and that kind of brings out the whole question of over treatment as well. And maybe we don't have time to talk about that now, but I suspect that there are a lot of people where we're giving them more treatment than biologically we need to, but it's just we don't really have a way of kind of measuring that, I don't think, very easily.
For a future podcast, let's talk about that adaptive trial, because I think that adaptive trial did exactly that. It tried to say, can we sort of tailor the amount of combination treatment for responding patients responding? Maybe you don't need the full induction. So we'll get there. But maybe the other thing I can ask you, as you've seen the long-term data on 067, do we know anything about the development of CNS metastasis? So in these treatment arms, in the long-term development of CNS metastasis, survival from CNS metastasis?
Yeah, that's a really important question. And I think it was at 3 years. I'd need to check if I'm honest. In one of the supplementaries, we did report some data on this question. And honestly, I haven't looked at it recently, but my memory of that is that numerically, in terms of the development of brain metastases as a site of progression or dominant site of progression, the ipi/nivo arm fared better than the anti-PD-1 monotherapy arm. But obviously that, this is a subgroup. It wasn't pre-specified. The numbers aren't really, that big, but hopefully before too long, we'll see some further follow-up data from CheckMate-067. And that, for me, that's one of the really important questions, because obviously brain mets are very difficult to deal with. And if it turned out that, that ipi/nivo gave you the best shot, shall we say, of not developing CNS progression, again, we'll talk about brain mets, I'm sure, in due course, but then that, for me, that's quite a strong argument, actually. And actually, that I need to footnote that as well, really briefly, to say that single agent ipi, if you like, back in the day, is active in metastatic disease to the brain. I think Kim Margolin was the lead author of the paper in the Lancet or the Lancet Oncology showing that. So it wouldn't maybe come as a massive surprise were that the case.
Yeah, but I actually think we're touching on another area for trial development and data capture, is we also have to make sure we're building in that field. Has the patient progressed? Where have they developed a brain metastasis? We have to ask these very specific questions, because I know, as somebody who looks at these databases, if you don't ask the question specifically, a site isn't going to give you the level of detail that you are going to think you need, years later. So we have to build the databases, now thinking about CNS metastasis. All right, good. So CheckMate-067 in summary is combination of nivolumab, ipilimumab. It was established as our frontline treatment really around the world, with a few countries still that just don't have access to these high-cost drugs, but it's really a standard frontline treatment with improvements in PFS, objective response rate, overall survival compared to ipi monotherapy, and numerically improved compared to nivo monotherapy. But of course, that combination comes at a toxicity cost. So, we have to manage those grade 3-4 adverse events. Any final thoughts about 067? Anything else we should think about other than waiting for the 10 and 20 and 30 and 40-year survival? Just kidding.
I think the final follow-up will be 10 years. Hopefully, before too long, we'll see those data. The questions you've raised are important, so let's hope we get some traction on those.
True.
No, that's fun, I think.
That's a wrap on CheckMate-067. Till next time, James. Cheers.
Cheers, bye.
Okay, now it's time for a quick fact check on CheckMate-067 and our discussion. James was describing the roundabout objective response rates of the 3 arms. And from the original publication, again, this is New England Journal of Medicine, July 2015, James Larkin et al. The objective response rate with ipi was reported as 19%, with nivo 43.7%, and with the combination 57.6%. I guess it's important to say that these were investigator-assessed responses, not blinded independent central review. And, in later years, the sponsor would come out to say these were unconfirmed responses, so that the confirmed response rate would probably be lower in each of those arms. That is to say, we all went around citing, high 50s for the combination and mid 40s for nivo. There was also a comment about the adverse event rate. So the grade 3-4 treatment-related adverse event rate in the ipi arm, 27.3, nivo arm, 16.3, and the combination 55%. And adverse events of any kind leading to treatment discontinuation in the ipi arm, 14.8%. In the nivo arm, 7.7%, in the combination, 36.4%. I think those are just some key numbers to grasp. I also made a statement about pseudoprogression with ipi, and I just wanted to confirm what that kind of rate of pseudoprogression was that we think we see with ipilimumab. It's right about 10%. And that's according to a JCO 2015 paper. So that same year as the CheckMate-067 original report. It basically describes that there's about 10% of patients who would have been classified as progression of disease if based on original kind of WHO criteria. And of course, immune-related response criteria is derived from that WHO criteria. So this is just to say, about 10% of patients have pseudo-progression. It looks like progression before response. Then finally, there was a comment on ipilimumab for CNS disease and the original Kim Margolin phase 2 study of ipi in brain metastasis, and was it published in Lancet or Lancet Oncology? This was published in the Lancet Oncology in 2012. So a very sentinel paper. So that's it for the fact check.